Okay, hello guys, good morning everyone. So today we are going to discuss the LIDS, LACRIMAL and SCLERA questions from yesterday's 6 p.m. quiz. Fairly easy ones, very straightforward. That's what I feel. Let's take a look. Yes, everyone ready? Shall we start? Okay, so and in the meantime, as students are joining, guys, you have questions regarding the test and discussion. See, test and discussion is happening 3 times a week. Okay, so Monday, Wednesday, and Saturday. So it will be live from 6 a.m. From that particular day, and you can take the test at any time as per your convenience. And it's a leaderboard quiz, and usually by evening 6, the discussion would be live for you. So I hope you all are not cheating, just watching the discussion and then doing it. Okay, so I trust you guys. So you can take the test, unlimited attempts you can take up to INICET. I have given the schedule. So the test and discussion runs until March 31st. The syllabus is complete, and April we will be doing revision tests. Okay, so 20 questions per test, and it's all unique questions, all prepared by me. It's not outsourced anywhere or not picked up from anywhere. Okay, and so based on my 15 years of teaching experience, so based on that, and yes, and my own intuition. All right, so it's based on that. So you let me know. I've given the link in the description for you to join, and the first 2 tests are free for you. You can take a look and then decide, okay, if it's worth joining or not. All right, so let's start with today's discussion. Which of the following are modified sweat glands in the lid? 1. Gland of Zeiss, gland of mole. Option C, tarsal gland. What is tarsal gland? Good morning, Bu. Good morning. So what is tarsal gland? Tarsal gland is your meibomian gland, okay, because it is present within the tarsal plate. So that is tarsal gland. All of the above. So which is the modified sweat gland? That is a question. And all of you again got misled by my wickedness where I gave all of the above option. Guys, meibomian gland, that is your tarsal gland, and gland of Zeiss, these two are modified sebaceous glands. Okay, these two are modified sebaceous glands. They are not sweat glands. So only your gland of mole is a sweat gland, a modified sweat gland. Is that clear? Put it in your brain box, imprinted in the brain. Okay, next question. Most common complication of alright. Most common cause of keratoconjunctivitis sicca. Okay, keratoconjunctivitis sicca is dry eye. Okay, it is dry eye. So what is the most common cause? It is rheumatoid arthritis, or if you have an option called Sjogren's, because rheumatoid arthritis is the most common cause of secondary Sjogren's. Yes, so if it is rheumatoid arthritis, that is the most specific answer, go for it. If there is no rheumatoid arthritis in your options, among your options, then you go for Sjogren's syndrome. Okay, so it means secondary Sjogren's. All right. Okay, so question number 3, most common complication of nevus of Ota. What is this nevus of Ota? You got this blue sclera along with a lot of pigmentation in the forehead and in the cheek. Yes, so along the V1 and V2 distribution, there's a lot of pigmentation. So that is nevus of Ota along with blue sclera. Okay, so that is nevus of Ota. So the question is most common complication of nevus of Ota. What is the most common complication of nevus of Ota? You want me to read out the options? Yes, there we go. Option A, blue sclera. Guys, blue sclera is a clinical finding of nevus of Ota. It's not a complication. So that cannot be the answer. Choroidal melanoma. Option C, glaucoma. Option D, scleromalacia perforans. Scleromalacia perforans, definitely not. Doesn't even occur. And blue sclera, yes, it is a clinical finding. Okay, it's a clinical finding. So option A is out, option D is out. Between options B and C. See, choroidal melanoma can also occur. That is, uveal melanoma can occur, and glaucoma, secondary open angle glaucoma, can also occur. Now my question is most common. Most common is glaucoma. Okay, most common is secondary open angle glaucoma. Is that clear? Is that clear to everyone? So nevus of OTA, 2 complications possible. So you always measure the IOP in such patients to rule out glaucoma. And number 2 is a melanoma, uveal melanoma. So you please do a fundus examination to rule out choroidal melanoma, because of all the uveal melanomas, choroidal melanoma is more common. Is that clear? Okay, so the answer to our question is most common complication of nevus of OTA is glaucoma. Next question, ciliary staphyloma may occur in, staphyloma means where the outer coat of the eyeball, either the sclera or the cornea is protruding, is bulging. Yeah, there's an ectasia. And also that ectatic outer coat should be lined by one of the uveal tissues. So when I say ciliary staphyloma, so in the ciliary region, it's only the sclera, right? Ciliary region is from the limbus to 4.5 millimeter from the limbus. So that is outer coat is sclera. So sclera is bulging and obviously it is lined by one of the parts of the ciliary body. What are the parts of the ciliary body? What are the parts of the ciliary body, guys? Simple question. Pars plicata and pars plana. Okay, so it could be any of that. So the question is, ciliary staphyloma occurs in corneal perforation. A corneal perforation means there is no sclera at all. If at all there is a staphyloma, it would be an anterior staphyloma. Yeah. So not that. Perforated corneal ulcer, same option A, worded in a different way, like all are right answers, no? You just change, if your English is a little good, you just change the words, use all the knowledge that you have from your thesaurus knowledge and use it. So like that, option B is derived from option A. So again, no, perforated corneal ulcer, if at all there is a staphyloma, it would be an anterior staphyloma, guys. Okay, option C, scleromalacia perforans, looks like. Option D, myopia. See, myopia itself will not cause staphyloma. Pathological myopia, when you have this huge eye, ballooned out eyes, no, that case you will get a posterior staphyloma and an equatorial staphyloma. So what is left? Scleromalacia perforans. So scleromalacia perforans can cause ciliary staphyloma. Good morning. Who's this? Ram Narayan Das ji. Good morning. Namaskar. All right. Next question, shall we go? Complication of lid coloboma. See, coloboma. Coloboma means, I know, I'm just talking like, I'm teaching LKG kids. Coloboma means a congenital defect or deficiency of any tissue. Okay, it could be a lid coloboma, iris coloboma, lens coloboma. So coloboma means deficiency of some tissue. So when I have a lid coloboma, so the lid lacks tissue. So most commonly it occurs in the upper lid. So it's like a V-shaped notch. So when I close my eyes, see, when I close my eyes, neither my sclera nor my cornea is exposed. So suppose there is a deficiency. Yeah, some part of my lid is missing congenitally. I have got a lid coloboma. So what will happen? Yes, my sclera and my cornea will be exposed. And if my Bell's phenomenon is not good, what about my Bell's phenomenon? What is Bell's phenomenon? When I attempted closure of eyelid, the eyeball moves, rotates up and out. Yes. So especially if my Bell's phenomenon is not that good or the lid coloboma is huge, the cornea can get exposed. So you want me to read out the options? I've told you the concept. So now let me read out the options for you. Neurotrophic keratitis. Keratitis means inflammation of the cornea. The exposed cornea can get inflamed. But neurotrophic means something to do with the nerve supplying the cornea. Yeah. So see, the nerve supplying the cornea is your trigeminal nerve, and it will secrete some neurotrophic factors. So when I have a trigeminal nerve palsy, or for some reason the corneal nerves, even the local nerves are damaged, then I will get neurotrophic keratitis. Okay. Remember, neurotrophic has something to do with the T nerve, trigeminal nerve. Nothing to do with my lid coloboma. Lid coloboma is going to cause exposure keratitis. Got it? So option A ruled out. Option B, exposure keratitis. Very common sense, no? See, you all think, no? No, it's not like that. So easy. It's just like that. Like this, you should be able to answer. Okay. Exposure keratitis. So lid coloboma. So my lid, there is some absent tissue. So when I'm closing my eye, the cornea is exposed because it is not closing properly. So exposure keratitis. Is that clear? So it's that easy, common sense. So option B is the answer. Option C, neuroparalytic keratitis. See, neuroparalytic keratitis, according to the textbook, it says facial nerve palsy. See, when you have a facial nerve palsy, there's going to be lag of thalamus. Yes, that means incomplete closure of the eyelids, again causing exposure, and that is called neuroparalytic keratitis. So again, no. Metaherpetic keratitis. See, metaherpetic keratitis, please do remember guys, although this is not a cornea session, I want you to know something. Metaherpetic is not because of active infection. See, once there is a viral infection, a herpetic viral infection of the cornea, there's a keratitis, the corneal nerves are destroyed. Yeah. And because of that, subsequently, what happens is when the corneal nerve is destroyed, I just said the neurotrophic factors are not going to be released. Yes, so the corneal ulcer will not heal. Yeah, the corneal ulcer will not heal. So you get a non-healing corneal ulcer. And also for the herpetic keratitis, the patient would have used topical antivirals, and antiviral drops are extremely epitheliotoxic. They're toxic to the corneal epithelium. So the two reasons. One, because of the damaged nerves, and also because of the toxicity of the epitheliotoxic nature of your antivirals, there is a non-healing corneal ulcer. That is metaherpetic keratitis. Is that clear? So for that, you have to use lots and lots of lubricants. Okay, lots and lots of lubricant eye drops, like your artificial tears. And these artificial tears, make sure that they are preservative free, because again, the preservatives in the artificial tears can be epitheliotoxic. Is that clear? So that is a treatment of metaherpetic keratitis. Long time ago, very long time ago, that was a question. Okay. So what is the management of metaherpetic keratitis? So, and also for neurotrophic keratitis, one of the management is giving preservative free artificial tears. Is that clear? Okay. Can we move to the, okay, so actually what is the complication of lid coloboma? Exposure keratitis. For that only all this story, okay, and you learned a lot more. Then what is the, which of the following is a myogenic ptosis? So there is ptosis, myogenic, which is a muscle related. There's a problem with the muscle per se. Third nerve palsy, third nerve palsy. Nerve palsy, that means it's neurogenic. Of course, it affects LPS, but that is not myogenic. The origin is because of a nerve problem. So that is a neurogenic ptosis, not the answer. Option B, myasthenia gravis. I think so. Anyway, let's move to option C, Honor syndrome. Honor syndrome, which muscle is affected? Muller's muscle. Yes or no? So if it is Muller's muscle, again, neurogenic. Although it is a sympathetic problem. Yes, it's an oculosympathetic palsy. Honor syndrome is an oculosympathetic palsy. Is that clear? Clear? Thumbs up. Neurogenic, so ruled out. Option D, congenital ptosis. Guys, congenital ptosis is a purely myogenic ptosis. Okay, purely. Although I thought myasthenia gravis, but comparatively between myasthenia gravis and congenital ptosis, which is the answer? Congenital ptosis. That is why I read all the four options. Okay. And now comes the one-liner. Which is the most common cause of myogenic ptosis? Congenital ptosis. Because the muscle itself, the LPS itself, is not formed properly. Okay. It's not formed properly. It's maldeveloped. So it is a myogenic ptosis. Yeah. So although myasthenia gravis also comes under myogenic ptosis, the best answer would be congenital ptosis. Which of the following is a myogenic ptosis? Is that clear? இப்போ தான சொன்ன BU congenital ptosis வந்து the LPS is not formed properly. Okay, LPS la வந்து see the LPS should have the levator palpebrae superioris, I mean, should have muscle fibers. Completely, purely it should be muscle fibers. But what happens is there are a lot of fatty tissue and a lot of fibrous tissue into the in place of the muscle fibers. Is that clear? So that is the problem in congenital ptosis. புரிஞ்சுதா? அப்போ muscle இல்லைன்னா see the muscle action is going to pull the lid up. The LPS action is going to pull the lid up. Yeah, it's a upper lid retractor. Correct? Suppose I don't have enough muscles, I only have fat and fibrous tissue there, then the muscle does not have the power to lift it up, correct? So that is why you have a poor LPS, you may have a poor LPS function in congenital ptosis, and that is exactly why you have ptosis. Yes, got it now? All right, let's move on to the next question, which is management of congenital dacryocystitis. Guys, this is very important question. Okay, congenital dacryocystitis in a 2-year-old child. See, congenital dacryocystitis means lacrimal sac inflammation. Where is the lacrimal sac located? In the medial wall of the orbit. Yeah, it's here. Yeah, so around just below the medial canthus, that is where your lacrimal sac is there. So when your lacrimal sac is inflamed, it's called dacryocystitis. And what is the cause of congenital dacryocystitis? When your NLD is not open. Nasolacrimal duct, which opens into the inferior meatus, is not open. Why? Because my valve of Hasner at the inferior meatus is not perforated. Normally it gets perforated or just opens at birth. It's like a solid cordlet, there is an opening which develops just at the time of birth. Sometimes it doesn't happen. It doesn't canalize. So in that case, there's going to be a congenital dacryocystitis. Now, what is the management? See, whether they ask you management of congenital NLD obstruction, NLDO, or congenital dacryocystitis, the protocol is the same, all based on age. So from birth to 11 months, please remember, birth to 11 months, all that you need to do is a lacrimal sac massage from the medial canthus to the ale of the nose. The mother will do, followed by topical antibiotics. Okay, so this is all that needs to be done from birth to 11 years. If you have a baby presenting to you from 11 months to 4 years of age, then we would advise syringing and probing, usually under light anesthesia. Okay, so syringing and probing, correct? And after 4 years, then you can advise DCR procedure, dacryocysto-rhinostomy surgery. Is that clear to everyone? So it is completely age based. So now what is our question? Management of congenital dacryocystitis in a 2-year-old kid. So 2-year-old kid comes under the second bracket. That is 11 months to 4 years bracket that I told you, where we are going to do lacrimal syringing and probing. So option A, lacrimal sac massage. This child is a little older than that, so not that. Lacrimal probing and syringing, I think that is the answer. Okay, option C, DCR, no. Option D, DCT, no. Yeah, so option B. Okay, so lacrimal probing and syringing. Very good, Ram Narayan ji, very good. Okay, next question. Muscle implicated in the ptosis of Horner syndrome. I just taught you when I was talking about neurogenic ptosis. So Horner syndrome is an oculosympathetic palsy. So what are the features of Horner syndrome? Ptosis, meiosis, anhidrosis, enophthalmos, and loss of ciliospinal reflex. So 5 things, I think that was what are the first things we learned in first year. And you're so excited in first year to learn about all the clinical things, where you don't want to learn anatomy, you want to learn the next step. So it is ptosis, meiosis, anhidrosis, enophthalmos, and loss of ciliospinal reflex. Now, out of these 5, the first 3 actually are the triad of Horner syndrome. Which are the triad of Horner syndrome? Ptosis, meiosis, anhidrosis. So when you say this, you always say in this order. I've been saying this for probably 25, 23, 24 years now. So I know it comes only in this order: ptosis, meiosis, anhidrosis, enophthalmos, loss of ciliospinal reflex. So leave out the last 2. The first 3 form the triad of Horner syndrome. Is that clear? Because they're so fond of asking triads for you. So what are the components of the triad of Horner syndrome? Ptosis, meiosis, anhidrosis. Ptosis, meiosis, anhidrosis. Okay. Now this ptosis is because of that sympathetic supply gone. Sympathetic supply to which muscle? Muller's muscle. Yes. So the ptosis, the muscle implicated in the ptosis of Horner syndrome is option A, LPS. No. LPS gets third nerve innervation, oculomotor nerve innervation. Horner's muscle. Horner syndrome, Horner's muscle. Okay, not Horner. It's Muller's muscle. Okay. Frontalis. No, frontalis gets facial nerve innervation. Okay. So your answer is Muller's muscle. Is that clear? Very good, BU. Very good. Okay, next question. Which of the following drugs increases the tear production and is recently FDA approved for dry eye? I will share the link of this. I think I've already discussed this drug somewhere. So option A, faricimab. See, faricimab is a bispecific antibody. Okay, it acts against your VEGF and also against angiopoietin. So that is an intravitreal drug. So it's not faricimab. Voralanib comes under tyrosine kinase inhibitors. That's for the posterior segment. Yes, Ecoltremon is the answer. Okay, loteprednol is a steroid, low potency steroid. Why would that increase the tear production? So the answer is Ecoltremon. I have discussed the mechanism of action. So at the end of the discussion, I will share the link of that video. You can watch it. Okay, it's beautifully. I've explained it very well for you. So note it down. So Ecoltremon, okay, like Pokemon. You all know Pokemon, no? So Ecoltremon. So Ecoltremon is increasing tear production, okay, and recently approved by the FDA for dry eye. Okay, next question. The image shows. What does the image show? Okay. So look at this image. So here, now you don't know where to see. Okay, when an image like this is given, you really don't know where to see. Okay, go and look at the options. What are the options? Options are ectropion, distichiasis, trichiasis, trichomegaly. So I know I have to look at the lid margin and the eyelashes. Okay, I look at the lid margin. There's no ectropion. I can't see the palpebral conjunctiva. It's all nicely opposed, the lower one and the upper one. I look at the lashes. There's no trichomegaly, it's not huge. Okay, there's no hypertrichosis either, but I can see an extra row of eyelashes. Can you see the extra row of eyelashes here in the upper lid behind the normal cilia? The normal eyelashes are here. This is the extra row. Give me a thumbs up, guys, if you can observe this. Do you see this? This is not trichiasis. Okay, so trichiasis is when it accompanies entropion. There's no entropion. And these are posteriorly located lashes, much posterior to the normal eyelashes, because they arise from the meibomian gland orifices. See, the meibomian gland orifices are located behind. Yeah. So actually, this is metaplasia of the meibomian gland. Do you understand? So this is distichiasis. There's an extra row, abnormal row of eyelashes. These are little tiny and usually they'll be hypopigmented. But this one is not hypopigmented. So do understand, this is not trichiasis. Trichiasis is misdirected essentially because of entropion. Is that clear to you? So I've actually changed the image, but distichiasis, once upon a time, quite a few years ago, it was an image-based question. That one. Yes. What is your doubt, BU? Bullseye maculopathy, you can make it out on your fundus examination. You can make it out on FFA, fundus fluorescein angiography, and also on fundus autofluorescence. Okay, so I'll explain to you some other day. Today we will just restrict it to LIDS, LACRIMAL, and SCLERA. Okay, so it can be seen. Yes, of course it can be seen on all the three. The bullseye maculopathy on your ophthalmoscopy fundus examination. It can be seen on fundus fluorescein angiography, the finding. Not as a bullseye itself, you will see increased hyperfluorescence in that area because of the window defect. You will see the choroidal hyperfluorescence, and also you will see a dark spot, a dark ring on fundus autofluorescence. Okay. Yeah. So guys, those of you who are asking for discounts, New Year sale is on. So take a look. We'll discuss in one of the fundus images. Okay, BU, don't worry. We have enough time. Let's keep this discussion to LIDS, LACRIMAL, SCLERA. Worry pannada. Anyway, I will teach you. No, they don't look similar at all. No way. They don't look similar at all. Okay, so guys, I will see you tomorrow. I guess today's evening test is orbit and trauma quiz. So tomorrow 6 p.m. on Telegram group, and tomorrow at 11 I will see you here. So have a good day, all of you. Bye guys. Ciao.